I am Varun Puri. I am a professor of surgery at the Washington University in St. Louis and a practicing thoracic surgeon and health services researcher. Smoking cessation in the perioperative period is highly advisable, and there is convincing evidence to tell us that it either helps or does not hurt the patient. And I'll summarize some of the evidence that is available to us from approximately 15 years of research in the field. As a matter of fact, in 2020, late in 2020, there was a large study published out of the Veterans Health Administration database. As one might know, the incidence of perioperative smoking is higher in veterans than in the general population, to the degree that approximately 50% of veterans coming in for lung cancer surgery continue to be active smokers. This particular study looked at the time period between 2012 and 2018. They divided patients into three groups: current smokers, patients who were recent quitters, that is, they had quit smoking either in the interval 2 weeks prior or up to 3 months preoperatively, or they were non-smokers. That means they had quit either greater than 3 months before surgery or had never been smokers. From their entire database, they performed a propensity score matched analysis. Hereby, they looked at individuals who were well matched for tumor or other comorbidity associations that they had for baseline in these patient populations. So at the end of the propensity score matching, they had 572 triplets of patients matched in these three arms. So they were the smokers, the recent quitters, and the non-smokers. They clearly demonstrated that the incidence of pulmonary complications was significantly higher in active smokers versus recent quitters. And there was a 48% increase. So the odds ratio 1.48 for risk of pulmonary complications, including pneumonias, atelectasis, or respiratory failure in the postoperative period in this population. Additionally, they assessed complications in non-smokers and recent quitters. And they essentially found that recent quitters had outcomes very similar to non-smokers, which they defined as people who had quit smoking either greater than 3 months before surgery or had never smoked. Additionally, there was another study in 2020 which looked at this precise topic. This study from a Japanese population looked at 753 patients who underwent treatment at 3 centers. And they mandated 4 weeks of smoking cessation prior to surgical resection. And they finally established 3 groups of patients. These were abstainers, that means who quit smoking 4 weeks or 4 weeks to 2 months prior to surgery, former smokers who had quit smoking greater than 2 months prior to surgery, or never smokers, patients who had either never smoked or had a distant history of smoking. Now, they saw 14% of patients were abstainers, 48% were former smokers, and 38% were never smokers. And the likelihood of postoperative complications in these 3 groups of patients were 15% for abstainers from 4 weeks to 2 months. Former smokers was 8%, which is very similar to non-smokers at 6%. So patients who had quit smoking greater than 2 months prior to surgical resection ended up having a likelihood of perioperative pulmonary complications very similar to never smokers, which is a very similar result that we saw in the Veterans Health Administration study. There have also been 2 large meta-analyses that have been conducted in these populations. And these meta-analyses are, however, about 10 years old at this point in time. They showed conflicted results, but since then, a lot of other information has become available in the field. Essentially, there was an American Journal of Medicine meta-analysis, which looked at 15 observational studies and 5 randomized control trials in the field. And they saw that there was a 41% risk reduction for perioperative smoking cessation for pulmonary complications, and each additional week of smoking cessation increased the effect by 19%. So the longer you were a non-smoker before surgery, the better off you were. However, in conflicting evidence, there was a Canadian meta-analysis which really showed that you required a minimum of 8 weeks prior to surgery before you incurred any significant respiratory benefit. But if you quit for greater than 4 weeks before surgery, then you had an improvement in your infectious complications, particularly wound-related complications in the postoperative period. While it is well established that it is advisable to quit smoking in the preoperative period before lung surgery, or for that matter, before any major oncologic resection or other cardiovascular operations, the period of cessation or abstinence prior to surgical resection is less certain. There have been many studies in the field, and they have often showed conflicting results. However, when one summarizes where studies are consistent, we see that most studies show that less than 2 weeks of preoperative cessation does not appear to have significant benefit. 2 to 4 weeks is where some studies have shown benefit in wound or other infectious complications. However, greater than 4 weeks of smoking abstinence or cessation prior to surgical resection is generally associated with at least a modest decline in short-term postoperative infectious, pulmonary, and wound-related complications. Many studies have shown that the longer the period of cessation, generally speaking, is associated with increased lowering of the risk of postoperative complications. However, by the same token, while it's important to have a period of time of smoking cessation, one has to balance that risk against the likelihood of cancer progression and moving to the point of inoperability or disease might spreading to other sites and becoming metastatic. There have been at least 2 studies in the field, both of them conducted by our institution, which have sort of assessed the duration of time between initial diagnosis and surgical resection, which is associated with either upstaging or likelihood of long-term adverse outcomes. One study, which was in the National Cancer Database, assessed a period of 8 weeks between diagnosis and treatment and found an increased likelihood of cancer progression in the form of upstaging at the time of surgical resection or diminished long-term survival. A second study, which we are currently conducting in the VHA, which is the Veterans Health Administration database, our preliminary findings suggest that a period of 12 weeks of delay between initial diagnosis and treatment is associated with decline in long-term survival. However, both of these 8 or 12-week intervals are significantly longer than the minimum advised for smoking cessation in the perioperative period. An important aspect of managing patients in the perioperative peritreatment period is what to do about smoking cessation. The most important thing to realize is one should have a programmatic approach to smoking cessation in the preoperative or pre-treatment period for patients with more advanced lung cancer. There are 3 important components to this programmatic approach. One is counseling. Every patient who's a current smoker at the time of evaluation for either lung cancer surgery or being considered for chemoradiation or other forms of treatment for lung cancer should be offered counseling. Many oncology programs have smoking cessation counselors or advisors available as part of their clinical setup who can see patients often at the same visit as their initial appointment with their surgeons or oncologists. The second important component is to offer pharmacotherapy. Pharmacotherapy should be tailored. Since nicotine replacement, Chantix, and bupropion have all been shown to have varying degrees of efficacy in different populations to help with smoking cessation, particularly in the peri-treatment period, this offering pharmacotherapy should be tailored, and patients may have different likelihood of side effects of or adverse effects from these particular smoking cessation interventions. And after a detailed discussion, one should pick one of these, often in consultation with the patient's primary care team. Finally, the third most important pillar of the programmatic approach is a discussion between the treating surgeon and the patient, and particularly that the potential for delayed surgery. Most patients are extremely keen to proceed with surgical resection as soon as they have a diagnosis of lung cancer. But if it comes from the surgical team that it's important to maybe even potentially delay surgery for a short period of time to improve short-term complications after surgical resection and not have adverse long-term cancer-related outcomes, then that's something that we have seen in our practice patients take very willingly too. Finally, it has been shown that home exercise programs in association with smoking cessation interventions often go hand in hand. And patients are often offered these as a bundle where you place patients in an exercise program, either supervised or unsupervised, along with smoking cessation interventions to prepare them for surgical resection. There have been several studies which have looked at the success rate of smoking cessation interventions in the perioperative period. At the low end, these point to numbers in the range of 20 to 40%. At the high end, 70 to 80% of patients in some studies have been abstinent from smoking after smoking cessation interventions in the perioperative period. Interestingly, when one looks at the long-term smoking abstinence in these patients who are able to quit in the perioperative period, it is not unsurprisingly somewhat lower. So between 50 and 60% of patients remain abstinent long-term after they've been able to quit in the perioperative period. Another question that is commonly asked by patients is, can I use e-cigarettes or vape to help me get off actual cigarettes in the perioperative period? The answer to that is we really don't know. There was a recent systematic review which showed that there was no clear effect of vaping or e-cigarettes on patients' ability to quit actual cigarettes in the peri-treatment period when they've been diagnosed with cancer. Finally, e-cigarettes themselves diminish microcirculation and blood flow to through microcirculation. So they may have wound-related or other healing-related complications after major surgery. Thus, one can't clearly suggest the use of e-cigarettes or vaping as a modality to help with smoking cessation in the perioperative period.